Welcome to As I See It. I'm your host, Dr. Jeff Kegarise. In this audio podcast series, we aim to focus on patient care, the service you should receive at any doctor's office visit, eye care education, our eyes are a precious sense, how do we protect, correct, and enhance your vision, and things that interest me, because I'm all about having fun and enjoying life. Today we continue to focus on COVID-19 and the experience and opinions of provider doctors. I'm pleased to welcome Dr. Ming Wang from the Wang Foundation for Sight Restoration here in Nashville, Tennessee. Dr. Wang is a Harvard and MIT graduate and one of the few cataract and LASIK eye surgeons in the world today who holds a doctorate degree in laser physics. Dr. Wang founded the Wang Foundation for Sight Restoration, a nonprofit organization which to date has helped patients from over 40 states in the United States and 55 countries. Dr. Wang is well known for many things. He's an excellent ophthalmic surgeon, a champion ballroom dancer, the founder of the Nashville chapter of the Chinese Chamber of Commerce, and author of many clinical textbooks, as well as his own personal autobiography. I also know him as Ming, and he's a really good guy. Dr. Wang has recently suggested steps to pursue when we do start reopening business as usual. Steps that would help us avoid a second wave of corona infection. I wanted to hear more from him and talk to him about his views and dig a little deeper into his suggestions. Dr. Wang, Ming, thank you for joining us today.
You're welcome. My pleasure.
Well, you are a healthcare provider, and one of the things that we always want to do is to recognize that you're on the front lines in this COVID-19 outbreak. So we thank you very much for your service to the community and the community of patients that you care for.
Thank you.
We're in a you're welcome. We're in a very interesting transitional time now. And one of the reasons I wanted to talk to you the most is that you've been a big proponent of preparation now for what may come in the future. I mean, we have faced stay at home and a virtual shutdown of our economy. Our leaders are anxious. Our people are anxious. Many of your and my patients are anxious. And some, if not most, are anxious to get back to normal. When is normal going to happen? Yet you are stressing that this is a particularly crucial time, possibly a particularly vulnerable time for us here in late April. Can you expand on that a little bit?
Yes. What I believe history is the best predictor for future. And if other people are doing the same thing that we'll be doing 2 months from now for us, they're doing now, the 2 months ahead of us, will be very useful. And if I look at in terms of why America has become the most infected nations on this planet with the most number of deaths, it has a lot to do with the fact that we got burned the first time, very bad, in late February, early March, even though President Trump closed the flight from China, which was the right thing to do. But at the same time, when the virus did finally hit America, late February, early March, many government agencies, we are basically, unfortunately, not well prepared. For example, CDC did not have the testing kits available for many weeks, resulting in our not having the ability to detect the early group of patients who got infected in America. So now there's a second critical time has come now, which is when our country reopened. In 1918 Spanish flu, 60 million people died. 1 in every 4 people on this planet. A majority died in the second and third outbreak.
That brings up, if you can help me with that, that brings up a good point. When does that second outbreak typically occur, or does it vary based upon the particular virulence of the virus?
Typically, it's about 2 to 3 months.
Okay.
Yeah, anywhere between 2 to 3 months. The reason for that is very interesting epidemiological question is because when it usually takes a few weeks for people to react, and then they usually end up social distancing, and then it's drastically cut down the transmission rate. And then usually, historically has been this way. I mean, we have the other virus affecting other countries in the last century more than us. Typically, the pattern is about like 2 months or so, a month and a half, the things will become normal. And if you don't watch out very critically at that moment when you reopen, the second wave will come. And the reason the second wave in the Spanish flu and others usually was worse in terms of number of deaths because and all that was because the first wave, you start with small number of individuals who are infected, and usually society reacted in a few weeks, and social distancing shut off the transmission. But when you open back up, usually, as proven in this case, COVID-19, there are a lot more people who are infected first time around, but they are not symptomatic. They are the silent carriers. In fact, we have just had this amazing experiment just concluded. Because anytime we talk about silent carriers, people always ask, we only test less than 1% of the US population. How do we know the number of silent carriers out there, right? So that's a very fair question. The answer came from an amazing answer, became just available yesterday, April 16th, 2020. Because the testing has been concluded, and the examination concluded for one specific group of people enclosed in one place, and with uniform populational characteristics, age and everything, which are the sailors on Theodore Roosevelt aircraft carrier. 5,000 sailors all being tested. So that's a miniature country. Okay?
Right.
We don't have all the other confounding factors. And the 600 test positive, and vast majority have never shown any symptoms. So here's the problem. That is a microcosm, and that, from scientifics, is a controlled experiment that actually we know, at least gets an idea, that this actually a question is being answered right now. So 600,000 Americans are test positive right now.
Yep.
Nearly all of them have symptoms. In fact, that's how you can be allowed to be tested. If you know no symptoms, then don't allow you to get tested because we don't have that much testing ability. So by definition, 600,000 all have symptoms. But if indeed the silent carriers are 5 to 10 times, that means up until 5 million Americans are currently infected.
Yeah, I'm not a math major, but if I do my math right, that 600 out of 5,000 seems to me to be about 12%. If you take 12% of 350 million Americans, that is a unbelievably huge number, isn't it? That are asymptomatic carriers.
Yeah.
Now, when they are asymptomatic carriers, do we know of those, Dr. Wang, how many can transmit the disease as opposed to who build up antibodies and is now at a point where they're not infective? Or is that a yet to be determined number?
We have actually a pretty good idea. COVID-19, even this early on in this disease, that vast majority, the bell-shaped curve, of course, majority in the middle, typical course is first week, no symptom, second week, symptom, fever, cough, malaise, taste change. Then 98% of us are healed after second week. And the 2% go on third week, continue sick, admission hospital, many of them get a ventilator, and 80% on the ventilator die. 80% on the ventilator die at the fourth week. So that's a typical disease course. So for the 98% or healed after second week, how long they are still shedding virus? Studies have shown on average 3 to 4 weeks. So that's the entire 6 weeks that if the average typical asymptomatic carriers, they are infectious. 6 weeks.
So that's even, just to clarify, that's a 3 to 4 weeks after their 3-week kind of time period of being within the active virus, correct?
Right. Exactly.
And
they continue shedding virus.
Yeah.
They continue shedding until 3 or 4 weeks after they have healed.
Wow, That's a scary proposition, correct? Do
Yeah.
we, and
And
we're about to be, in fact, I think the governor has announced that in Williamson County and other parts of the state, certainly here in Middle Tennessee, we're going to be testing more people. And what I hear you saying is, and they're going to be testing centers. You can go in, get tested. So I have a couple of questions on that. Number one, what I hear you saying is, okay, so if you go in, you get tested and you're negative, that doesn't mean though that you could still be a carrier, number one. Is that right?
well, there are two kinds of testing, right? The testing of the actual virus and testing of your antibodies. The nose swab test is testing the presence of antibodies, and the fingerprint latest testing and some blood drawn testing coming out now is testing the presence of antibodies. Testing of virus is active infection. That's 6 weeks course, as I told you.
Mm-hmm.
Even for majority asymptomatic carrier, that's 6 weeks active infection. Okay, presence of virus. That person will have the antibodies for the entire year. So antibody testing will be showing positive, but will be entire year. Of course, after 6 weeks, you no longer have active disease, but you're immune to it, right?
Mm-hmm.
So the thing is, the second wave historically in many infectious cycles has been worse, is because you're starting with a larger base. Initially, think about first wave, early March, we may say, Seattle, Washington, 10, 20, 30 infected patients, right? So they're very small base. The moment where we open the floodgate, early May, we're releasing potentially 5 million silent carriers, infections, from their home confinement right now. All of them at home, confined, back out into open society. So that's why, because when you start with a larger base number, that's why any transmission can cause even more deaths the second time around. That's the reason for that.
And this is a really scary thing because so many people get this sense of bravado that, hey, I feel great. I must have already had it and recovered, and I'm in good shape. I can't infect anybody. Let's get this economy going. Let's get out in the world. I'm going to do everything. And yet that asymptomatic nature makes it a very, very difficult thing to control, doesn't it?
Yes. Not only that, that an asymptomatic person, let's say this person is healthy, no problem, say 30 years old, when he or she may just be able to survive the whole disease without even knowing it. And the Theodore Roosevelt experiment showed majority don't know it. Just went to whole body. But the problem is this young person, socially more active than an older person, generally speaking.
Wait a minute, you're not talking about me, are you? You're talking about other people besides me, right? Okay.
You and I are still young.
Okay, good.
We're still working. Yeah.
Age is a relative thing, right?
That's right.
Keep going.
And the point is that this person may not be sick or symptomatic because this person, Johnny, happened to have strong, healthy body and no problem, right? That's why he didn't even know anything, right? My friend Rand Paul, the senator, then when he got test positive, he and I actually exchanged email and said, do you have any symptoms? He said, no, I have no symptoms. I said, good. So watch out, another week and a half. And he's coming out good. Now, the point is, this person, Johnny, 30 years old, carried the virus, as I said, 6 weeks, will be in contact during that 6 weeks with, I don't know, thousands of people. And lots of them are older.
Right.
And 80% of deaths are over age 55 so far, COVID-19. So all the elderly, medically sick, diabetes, hypertension, cardiovascular disease patients who unfortunately in contact with Johnny, of course not Johnny's fault, he didn't even know he's positive.
Right.
They will die. That's the problem.
Yeah. So let's get right into this then. This is a potentially devastating type of thing. We have tests now, nasal swab to detect active virus. I understand that the false negative rate on that though is higher than we would like. You have to get a good sample. And I know that in the ER, typically they're going to treat people symptomatically, whether they test positive or not. They're going to quarantine for 14 days based upon clinical symptoms. How close are we to having a reliable antibody test that says you have been exposed and you have built up antibodies to it?
Yeah. There's good news and bad news to the Excellent question. Number one, the technology actually, as we speak right now, are pretty good. I'm talking about 90+% accurate, sensitive in terms of that. There's false negative, of course, and with a swab it has some false negative, but they combined together when you have all these tests. Generally, pretty good. That's not the bottleneck. The bottleneck right now, we only have less than 1% U.S. population being tested so far. We are the least tested nation on this planet. No country, in terms of Western and Asian countries, has test rate less than us, which is less than 1%. Okay, so we have a long way to go. Now, the bottleneck is not the scientific accuracy, which are already pretty good at that. The bottleneck is the sheer reagent and testing ability. That's the bottleneck. So, given that limited, given the fact we cannot afford to keep the country closed beyond May, at least for some states, right? So that's why I suggest these 7 specific measures. These are measures I learned from my colleagues. As you probably know, that I'm part of the hospital group with 600 some locations, 400 in China, 85 in Europe. So I know, first line ophthalmologists and the doctors in Italy, Spain, China, South Korea, Japan, Hong Kong. So I have firsthand knowledge about what's working in preventing second wave because they already open, right? They already open.
Right. And in fact, kind of an interesting point, and for all I know, you may have known this gentleman, but I believe it was an ophthalmologist in China that was one that was alerting the authorities to a high number of these particular cases, right? And unfortunately, met his demise from the disease also. So.
Yeah, and he was a whistleblower. He died because he continued to take care of the patient. And after, it was remarkable. He's a hero.
Yes.
His wife works for our eye hospital. So our eye hospital, in memory of him, actually decided they have 2 kids. One is in her stomach, not born yet. One's 4 or 5 years old.
Wow.
So our hospital decided we're going to take care of these 2 kids basically until they're 18. All the expenses.
That is
in
tremendous.
memory of Dr. Lee.
Because you're right. There is no telling how many lives he saved with his selfless.
Yeah.
So let's get into the first one. You said reopening should be gradual, right? Tell me about that.
Gradual open, yes. And that means high priority. Like your clinic, my clinic, some of the medical facilities, some of the high priority, more necessity type of thing, we should be opening. People need to live because we have to open the economy gradually. And in those facilities, everybody entering your clinic, my clinic, has to have temperature checked. Okay, so that's number 1. Number 2, for these early to open businesses, such as medical clinic, I advocate test everyone. Now, there's not that many people. We have in our clinic, 28? For your clinic, probably a little bit bigger in number. But you can buy these reagents. I'm looking into that. I'll be happy to share with you. Probably cost, $30, $50 a shot or something. So I want to buy these for all my staff and test all of them. Okay? And I'm going to identify 1 or 2 silent carriers, possibly. Depends on, the chance. And then that person needs to stay home at least for that, 2 weeks at least, and we'll watch out everything. Right? But what that would do, though, is that we as important essential business, but at the same time, large contact with population, right, or the patient walking, that I want to give my patients the peace of mind. They say, okay, they come to, your Cool Spring Eye Clinic, Dr. Jeff Kegarise practice, or Dr. Wang's, that, that really we have taken an extra step in testing ourselves, our staff. So they are entering the environment where none of the cats. Because think about who are the high-risk professionals. It's us. It's the policeman. It's the nurse. It's the doctors. It's the paramedics. And the restaurant servers. It's the supermarket attendees. Because these people have multiple day-to-day large number. So they are potentially the highest transmitter. Okay, most dangerous transmitter as such. So my second proposal is testing people in those early to open businesses. Number 3.
Let me before we go to number 3, Ming, let me talk about number 2 again. When you're testing, do you advocate testing these people for asymptomatic carriers? I have active virus, but I don't have symptoms. Or are you advocating that we test them for antibody development, or is it both? Do we end up with you've been exposed, but you recovered, you didn't even know it, you are asymptomatic, you have it, you need to go home, and then this third category of people that haven't been exposed, don't have it, they're still at risk? I mean, how is that what you're kind of saying?
Yeah, excellent question. You got a very logical, scientific mind, the Kegarise, and you already basically see the picture of this. It's a 2x2 table, right?
Mm-hmm.
Basically, we've got two kinds of testing. The virus testing is called diagnostic test, and antibody testing. Okay, these are two distinct different tests, tell different things. So you got a combination of 4, right? 2 times 2.
Yep.
You're going to have some population who is virus positive, antibody negative. Some is the other way. Some are both negative, both positive. Okay, so you have to treat each of these 4 possibilities differently. Somebody who is testing positive for virus, that means they have active virus, but immune system has not kicked in yet. Of course, you got to send them home. They cannot be, because they're going to have symptoms very soon, likely, not necessarily, but also, they're going to have shedding virus for some weeks after that. So that's that.
Mm-hmm.
If someone who is negative, that's a clean person, right? Now, today, negative, doesn't mean this person will be negative tomorrow either.
Right.
Because he or she could be contact tonight because this person has no antibodies and no viruses. So white clean person, which most of us will be after this first wave, it's going to be still vulnerable. But at least we know that person can continue work in our clinic, no problem.
Do you think that population should be retested in a month, for instance?
Great question. Nobody knows. All depends on one single bottleneck, has to be the availability. Right now in America, if you want to just, negative, you want to be a month to be tested, it's not available. Right now, the only way to get for people to get tested in America is you have to have symptom, you have to have a known contact with COVID-19 positive in the past week. I mean, you have to jump through hoops right now to get tested because not enough facilities. Okay, so the specific facilities will be key. But in the ideal situation, yes, maybe a month later you have to retest. So negative can be working. So how about positive negative? Or which I'll talk about. The virus but no antibody. How about negative positive? That means no virus right now, but has the antibodies. That's my, that's my number 3 recommendation. These are people should come back, okay? Because they have no virus and they are test positive. That means they have the infection. Some weeks ago, they didn't know. And basically they healed, and not only healed, they in fact no longer shedding virus. The reason you can tell they're not shedding virus because their diagnostic viral particle test negative. So negative plus, minus plus patient, negative for virus, plus for immune, it's the best patient, best staff to bring back. So this person is not going to get infection with 99% confidence because 99% of people with COVID-19 has not demonstrated reinfection.
I think that's an important point I want to reemphasize because that was going to be a question I was going to ask you. Does this virus mutate, and can people get a second infection that is a COVID-19 variant that even if you developed antibodies to the first round, you might still get it again? Or are you saying that's a really, really low percentage in what we know medically today?
Yeah, I will tell you based on data at the moment, over 2 million infected already, and the 99.9% have not demonstrated second infection. Now, there are a few cases now, huge cases in some Asian countries, second infection. And the best they can tell, it seems that these are not second infection, but the person, medically sick or not very strong, actually never completely healed from the first time. So it's a viral activation. Because some viruses live in the body, 6 weeks of bell-shaped curve is the standard.
So that's like the patients you and I see that have an inflammatory eye disease, a uveitis, and we treat them with steroids, and they go, boy, am I feeling better? And all of a sudden they start tapering down on their medicine too soon, and it was never fully resolved. It's still lingering there, smolders, and then it comes back with a vengeance, right?
Exactly. So few cases in the world so far been demonstrated what thought was to be a second infection appears to be a just incomplete resolution for the first time. Okay?
Okay.
So at the moment, there's no strong evidence to demonstrate a second infection on the already immune person. However, the immunity is not expected to last more than a year. In fact, our seasonal flu shot every fall, we get every year. You cannot get a seasonal flu shot, in the past years, just immune for 5 years. That doesn't work. Every year is supposed to get it.
Right.
Because the flu shot, but by the way, our traditional flu shot in peacetime, so to speak, before COVID-19, 20% of those flu shots is against coronavirus. Already, it's a different strain, not COVID-19, but different type of coronavirus. So that's why we need to. So the immunity, even for this, minus plus, meaning no virus but has antibodies, so these patients are immune, only supposed to be a year only. Okay, so hopefully the vaccine can develop next year.
Safe and good for a while, but not forever, right?
Yes. The last combination is, let's see, we talk plus plus. And if you have virus and you have immunity, that person is pretty much dealt with as the first group, plus minus, because they have virus. Once you have virus, all bets are off. You have to stay home or be treated. Okay. So to answer your question, none of the two tests, the viral test or antibody test, tell the whole story. You have to get both. If you have to generate this 4x4 story, and you once you generate that, in fact, it may be a good idea because you cannot test one. If that's you test just virus, well, that can do something because if you have virus, you have to stay home. But if you just test virus, you don't know whether the person has antibody or not. So if it's a negative for virus, you don't know. Because there are also quite a bit of population, as I mentioned, asymptomatic carriers, many of them here already, they have antibodies. They don't have virus anymore. So some of these can come back to work. So get the whole picture, you have to do 2 by 2. So that's my third point.
Yeah, I'll tell you what, Ming, hang on just a second because we're running a little longer, but this is such an interesting and such an important point that we're gonna take a very, very short break, and we're gonna come back and do the second part of this. So for those of you that are just joining us, I'm talking to Dr. Ming Wang. Dr. Wang, as you may be aware, is one of the few cataract and LASIK eye surgeons in the world today who holds a doctorate degree in laser physics. He founded the Wang Foundation for Sight Restoration. He practices here in Nashville, Tennessee. He is a tremendous ophthalmic surgeon, but we're talking more public health today. And in the first section, we have discussed the imperative of not considering that the first wave of COVID-19 means we're out of danger. In fact, in past epidemics, as Dr. Wang has pointed out, it's the second wave that is more critical and causes more morbidity and mortality. So we're talking about what can we be doing now with our existing staff, our patients, with the community, as we start to open up things. How do we know if that's safe, if it's not, so that we can try to, if you will, flatten the curve of this second wave that's coming? We covered a couple points now, and we're getting into 3 of 7 main points that Dr. Wang's discussing. And I'm going to turn it back over to you, Dr. Wang. What is that third point that you would recommend for us in our communities now in view of the potential for a second wave of COVID-19?
Yeah, when we reopen. And the third measure, again, these measures are what I learned from these other countries, which is working as they are combating right now for the second wave, which we will be combating in May and June here when we reopen, is bring back only those preferred people to bring back to work first is those people who are immune already. And through the discussion, we showed that if someone was infected, you have to wait for a few more weeks after they heal to make sure they're no longer shedding viral particles. And there's some silent carriers who just gone through the whole infection without even knowing. So they have the antibodies, but they have no virus particle. So those can be identified. And this only can be obtained through this combination of the 2 testing, the virus for the diagnostic test and the antibody test. So those people, we're not going to identify all of them. Whoever identified, they're very safe to be brought back to work.
One thing I want to ask again, though, Ming, is we have heard that this antibody test that would tell if you have the antibodies that it's coming. You're saying there's basically a delay in the supply chain. We have the technology to do it, but the supply chain is limiting us right now. Is that correct?
Continue this conversation by downloading the next episode to hear Dr. Wang's answer to that question and many more.